Hi and welcome to CLD Multimedia Journal. I'm Vicki Shaw, and today I'll be interviewing Dr. David Thomas from Johns Hopkins on his article. Hi and welcome.
How are you?
I'm good. How are you doing today?
Fine.
So I wanted to go over your article you submitted with us, the state on Hep C care cascade. Can you tell us a little bit about the care cascade?
Yeah, the care cascade refers to the degree to which a given country, let's say, or entity within a country delivers the tools that are needed to control an infectious disease. So, for example, it starts with finding out the people that are infected, diagnosing. Then, among those who are diagnosed, linking the ones that are positive to treatment, and then of those that are linked to treatment, delivering the care to them, and then obviously curing the ones that receive care. There's a little bit of an expanded version that I like to consider, which also includes preventing those who have been cured from being reinfected,
Yes.
which is important in some populations, and preventing new infections from occurring within the whole population. So collectively, that whole process of considering what's going on with hepatitis infection is considered the cascade of care.
So we know across the world we have discrepancies on linkage to care. In your paper, you describe two different countries. Can you kind of go over that?
Right, so I contrasted a low-income country like Pakistan with a very high burden of infection. So Pakistan is one of the 5 most affected countries in the world, and it's thought that there's somewhere around 8 million persons that have hepatitis C infection, but a relatively low income, and those infections are distributed all around Pakistan and can be very difficult to reach the people who are positive. No more than 1 million knew that they had their infection,
Yeah.
so that would be less than 20%. And so then the question is, how do you find all of the infected individuals and test them, and how would that work, and then how would the country be able to afford it, and what would the net impact of all that be? So I think that's an important example of how tough elimination can be. You have to test, it's estimated more than 20 to 30 million people just to find another million that are positive and tell them that they're positive. And then you have to be able to deliver care to them and hopefully test and find them in a place where there's also the kind of medical facilities that can provide treatment and access to the drugs and that sort of thing. So that, on one hand, underscores how hard elimination can be. The situation in Pakistan will be challenging. On the other hand, I brought up Iceland.
Yeah.
So Iceland's a relatively high-income country that has no more than what's thought to be 1,000, instead of 8 million, just 1,000 people infected with hepatitis C. And they have a national elimination plan. They had a program that they worked out with Gilead to provide medication. And they even had a registry where it was already sort of known who was hepatitis C positive in the country, because they had been keeping track of that since really way back into the 1990s. So in that context, it was, once the program launched, it was relatively easy to find the people, contact the people who were positive, and to distribute the treatment to them, which was free of care for the patients affected. And so they're already effectively have eliminated hepatitis C from Iceland, whereas Pakistan really has a very, a much more challenging situation. And in between that, there are lots of other really good examples, countries like Egypt that have just as big a challenge as Pakistan, and even larger, where already 50 million people have been tested. Just an amazing tour de force of public health commitment. And then others where there's different degrees of elimination that have occurred.
Yeah. When we look at global health as a whole, how would you compare Hep C to those other issues that we deal with, like malaria or HIV?
So there's 5 infectious diseases that cause most of the mortality in the world. That's tuberculosis, HIV, malaria, and then hepatitis B and C. And if you look over time, really they've been keeping track of this pretty well since the 1990s. The mortality due to HIV, due to malaria, and due to tuberculosis has been dropping since about 2000 and 2004. And in contrast, mortality from hepatitis B and C keeps rising.
Yeah.
So why would mortality from 3 big problems be dropping? And why would mortality from the hepatitis viruses be rising? And more importantly, the current projections are that mortality from hepatitis B and C will, in 2040, exceed the combined mortality from HIV plus malaria plus tuberculosis. Take all 3, add them together, and you'll have fewer than 2 million deaths in 2040, whereas with hepatitis B and C, there will be just over 2.2 million deaths unless we do something different. And the reason is that right around 2000, global health programs began for HIV, for tuberculosis and malaria, something called the Global Fund, and there's some other variations on that. But in effect, the world decided that it would no longer think about those 3 infectious diseases as something that should be dealt with between an individual patient and their medical provider, but rather that they should be dealt with in a public health way. Their treatment should be moved into governments and ministries of health and approached in a more comprehensive way. And so it's not surprising that mortality from those 3 is dropping, while with no equivalent global effort to eliminate hepatitis B and C, mortality is rising and expected to be exceed the mortality from all 3 of the others.
Yeah, so we have a lot of work ahead of us.
We do.
Well, thank you so much for joining us today. If you would like more information, please visit cldlearning.com. Thank you.